Beth Israel was founded in 1889 as a hospital to take care of all the immigrants coming into New York City. It's an academic medical center and has close ties to the community, so in that sense it's a hybrid, both an academic medical center and a community hospital. The Department of Psychiatry is a large department. We are very much committed to providing excellent patient care in an empathic and caring manner. We believe that education and research and community outreach is an important part of what we do and very much helps in the delivery of good care to our patients.
In every clinical program, we try to provide the best possible care and enhance patient satisfaction by establishing quality improvement programs. A number of quality improvement projects are mandated by governmental and regulatory agencies, while others are developed in the department according to specific issues that arise, clinical interests, and academic interests. Our experience shows us that a dedicated and dynamic quality improvement program can enhance outcomes of care, can lead to systemic performance improvement, and professional development. Every resident is involved in quality improvement by the time they complete their training.
One thing that we're uniquely focused on in our Beth Israel residency program is to train residents who really have the skills and the confidence to practice psychotherapy, because we know that psychiatrists in general are less frequently using psychotherapy in their practice. So our residents get the supervision to be able to practice multiple forms of psychotherapy. But at the same time, we also have the Yarman Neurobehavior Center, which gives great clinical exposure to neuropsychiatry and a terrific curriculum in the neurosciences, so our residents are prepared for all of the discoveries that will occur with the brain in the years to come.
The Yarman Neurobehavior and Alzheimer's Disease Center was established in 1986. The main focus of our program over the years has evolved more toward the dementias, including Alzheimer's disease, as that has become one of the most prevalent disorders that we have to deal with. In addition to that, we deal with a combined neurological and psychiatric conditions, so that includes traumatic brain injury, stroke, and other varieties of dementia where you get a disturbance of both the neurological and the psychiatric aspects. The Neurobehavior Conference is based upon 30 years of compiled neuropsychiatric cases that I've developed over the course of my career. The purpose of this is that we only have our residents for 2 months. What using the videotape enables us to do is to show them a whole range of neuropsychiatric and behavioral neurological conditions over that shorter interval. They have the opportunity to really study, discuss them, and integrate the clinical with the brain imaging, with the brain anatomy, and with the literature to get a much more complete picture of what these things are all about.
We have developed a system where every single resident, starting at least in the PGY2 year, has a research mentor that helps them develop their own project or work on an existing project, and so they really understand how research works.
We take research very, very seriously. We believe that any clinician needs to understand research in depth. Only then they can practice evidence-based medicine. So everybody in the department is doing research. Our faculty functions as mentors, our residents are doctors in training, and they function as mentees. In the process, we become kind of hybrids. We're all clinicians, and to some extent, we're all researchers. We kind of have a hybrid department in that respect. And the Family Center for Bipolar Disorder is an example of such a hybrid enterprise. The mission of the Family Center for Bipolar Disorder is to provide the highest quality of care for a patient in the context of the family. So we function essentially as family psychiatrists. And family inclusive treatment is a modular approach that combines engagement period, open-ended treatment for the patient and the family, and different models that including family therapy, wellness maintenance, consultations for family and the patient in different combinations tailored to the individual family. Bipolar disorder is a serious illness, and you cannot talk about it without talking about suicide. We here developed a new research program which has a new approach trying to predict suicide and prevent suicide and reduce suicide risk by defining suicidal state. And we have defined a new syndrome. It's called suicide trigger state. It consists of ruminating, flooding, and frantic hopelessness. And using this approach, we had some success in predicting imminent suicide.
In the Department of Psychiatry, we have the brief psychotherapy program. We are very interested in the researching process and outcome in terms of what happens with our patients. We focus on patients with cluster C personality disorder, and we're very interested in the patient-therapist relationship, the therapeutic alliance, and we work very carefully in that arena.
An assertive community treatment team is a team of various professionals consisting of doctors, we have nurses, we have caseworkers, we have social workers. We are much more involved than just your regular psychiatric visit in the office. So we follow the patient closely, we know how they live, we know their loved ones, we know the fabric of their lives. And we also specialize in certain areas. So we have a substance abuse specialist, for example, we have a family specialist, we have a vocational specialist. So there are all these angles from which the patient support is provided. It's a very beneficial model of treatment that keeps patients out of the hospital and keeps them stable and helps them recover and gain insight into the illness.